Good morning. Let's begin. We're here today to go over your approach to a common but quite complex surgical problem. I'll be looking for a consultant-level discussion, so I expect you to show clear clinical reasoning and sound surgical judgment.
Right then, here's your case. A 65-year-old patient has been diagnosed with an adenocarcinoma of the mid-rectum. Tell me, how would you proceed?
Thank you. I'd approach this case systematically. I'll start with a complete patient assessment and workup, which is really going to guide my surgical plan and the choice of operation. Then I'll walk you through the key steps for both a low anterior resection and an abdominoperineal resection. And finally, I'll cover the essentials of postoperative care and how I'd manage any potential complications. Okay, so the first and, arguably the most critical phase is the initial assessment and workup. Getting this foundation right is absolutely essential to make sure we're picking the right operation for the right patient and getting them in the best possible shape for surgery. This means a detailed history, a really focused physical exam, and of course, all the appropriate staging investigations. My priorities here are twofold: oncologic staging and functional considerations. So first things first, I need to clinically assess the quality of the anal sphincter with a digital rectal exam. Is a sphincter sparing procedure even on the table? Next, accurate staging is paramount. We use the TNM system for this. So that's assessing the T stage, which is the tumor's depth, the N stage, looking for lymph node involvement, and the M stage, screening for any distant metastases to make sure we're proceeding with curative intent. My key investigations would be a pelvic MRI. That's going to give me a precise map of the local T and N stage and its relationship to the mesorectal fascia. And then a CT of the chest, abdomen, and pelvis for metastatic disease. One last critical point: if the patient has had neoadjuvant therapy, chemo, or radiation before surgery, the timing is crucial. We typically wait about 8 weeks after treatment. This gives the tumor time to respond and lets the tissue inflammation settle down.
To get the patient ready, a few steps are absolutely vital. A full mechanical and oral antibiotic bowel prep is needed to cut down on septic complications. We'd also give perioperative IV antibiotics. And just as important, I'd sit down with the patient and have a very detailed, honest conversation about the risks, things like potential sexual and bladder dysfunction from pelvic nerve injury. We have to manage their expectations about bowel function after surgery. This is where an enterostomal nurse is just invaluable for counseling and marking potential stoma sites beforehand. And of course, if the scan suggests the tumor is touching nearby structures like the bladder or sacrum, I'd get urology or orthopedics involved early for multidisciplinary planning.
Okay, so now we get to the decision point, selecting the correct operation. This is all about balancing complete oncologic clearance with the possibility of restoring bowel continuity and really preserving the patient's quality of life. Precisely. So what are the primary factors that make you choose a sphincter-sparing operation, like a low anterior resection, over an abdominoperineal resection, which, as you know, results in a permanent colostomy?
The number one deciding factor is whether we can achieve adequate cancer-free margins while also creating a functional and reliable anastomosis. That's the surgical reconnection of the bowel. For a low anterior resection, or LAR, the goal is saving the sphincter. This is usually possible for upper and mid-rectal cancers, where we can get at least a 2-centimeter margin on the bowel wall itself and a 5-centimeter margin on the mesorectal tissue around it. In contrast, an abdominoperineal resection, or APR, becomes necessary for those really low rectal cancers that are just too close to the sphincter, or for patients who already have poor sphincter function, or when the tumor is actually invading the sphincter muscles. In those cases, complete tumor removal means we have to sacrifice the anus, which means a permanent colostomy.
All right, so assuming this patient's mid-rectal tumor gives us enough room for good margins, my procedure of choice would be a low anterior resection. And this has to incorporate the principles of a total mesorectal excision, which is really the gold standard for this operation. I'll outline the key steps now.
This image here really highlights the vascular anatomy, which is just central to the whole procedure. Early on, we'll perform a high ligation of the inferior mesenteric artery and vein, right where they come off the aorta. This is a critical move. Not only does it get us a complete apical lymph node dissection, but it also gives us fantastic length and mobility on the left colon. That mobility is essential for creating a tension-free anastomosis deep down in the pelvis.
So the procedure starts with the patient in a modified lithotomy position. We have to be meticulous with padding to prevent any nerve injuries. After a midline incision, we do a thorough exploration to make sure there's no unexpected metastatic disease. Then we get a Bookwalter retractor in for exposure. The first big step is the medial mobilization of the sigmoid and descending colon. And the key landmark here, the structure you have to find and protect, is the left ureter. We need to carefully sweep it away from our dissection plane to avoid injuring it. The cornerstone of modern rectal cancer surgery is, without a doubt, the total mesorectal excision, or TME. Now, this isn't just about taking out the rectum. It's a meticulous, sharp dissection that happens in a very specific avascular embryological plane. It's often called the holy plane. This technique ensures that we remove the rectum and its entire lymphatic package, the mesorectum, as one single intact specimen. And this has been proven to dramatically reduce local recurrence rates. So the most important thing during the posterior part of the TME is staying in that holy plane. This quote here highlights the most feared technical mistake: straying from that plane and getting into the presacral fascia. If you do that, you can cause catastrophic, really difficult to control bleeding from the presacral venous plexus. Sharp dissection under direct vision is absolutely mandatory to avoid this. So once the posterior and lateral dissections are done, we move to the front, dissecting in front of a structure called Denonvillier's fascia. Here, we're being incredibly careful to preserve the autonomic nerves that control sexual and bladder function. The rectum is then transected with a stapler, making sure we have our distal margin. Then we create the anastomosis, which absolutely must be tension-free and have a great blood supply. We always test its integrity. We check the donuts from the stapler, and we perform an air leak test. For these very low anastomoses, I would almost always create a temporary diverting loop ileostomy. This diverts the stool, protecting that new connection and really mitigating the consequences if a leak were to happen. This image shows that final step of reconstruction. You can see the circular stapler being fired to create the coloanal anastomosis. The anvil of the stapler is secured in the colon, it's passed down and connected to the stapler body, which we've inserted through the anus. When you fire it, it simultaneously staples the two ends together and cuts a new opening. It's a really elegant technique for restoring continuity deep in the pelvis. Now, let's say that intraoperatively, I found I just couldn't get an adequate distal margin, or if the tumor was clearly involving the sphincter. At that point, I'd convert to an abdominoperineal resection. This operation shares some of the same principles, but obviously has a very different conclusion for the patient. The abdominal phase of an APR looks a lot like the beginning of an LAR. We do the same colonic mobilization, we identify the ureters, we do the high ligation of the IMA, and we perform a total mesorectal excision. The key difference is where the dissection stops. Instead of getting ready for anastomosis, we take the dissection all the way down to the levator ani muscles, the pelvic floor. The proximal colon is divided, but the distal end is left attached to the rectum, ready to be removed from below. Then comes the perineal phase. We suture the anus closed to prevent any tumor spillage. A wide elliptical incision is made around the anus, and the dissection proceeds upwards through the fat of the ischiorectal fossa to meet the abdominal dissection plane at the levators. This allows the entire specimen, rectum, anus, and mesorectum, to be delivered out through the perineal wound as one single en-bloc piece. And finally, the permanent end colostomy is fashioned on the abdominal wall. Finally, my management plan would wrap up with meticulous postoperative care and being vigilant for any complications. The operation isn't really over until the patient is safely recovered. Right. Before closing the abdomen, I'd make absolutely sure hemostasis is complete, irrigate the cavity, and consider placing pelvic drains. In an LAR, I'd bring the omentum down into the pelvis to buttress the anastomosis. It can help contain a potential leak. After a standard abdominal closure, the patient would be monitored very closely in the recovery unit, looking for any signs of bleeding, pain, or hemodynamic instability, and keeping a very close eye on urine output as an early sign of their fluid status. Very good. One final question then. It's postoperative day 5 for your low interior resection patient. He develops a fever of 38.5, he becomes tachycardic, and he's complaining of generalized abdominal pain. How would you investigate and manage a suspected anastomotic leak? A suspected anastomotic leak is a surgical emergency and a major red flag. My approach would be immediate and systematic. First, I would personally assess the patient using an ABCDE approach, ensuring they are hemodynamically stable. I would start immediate resuscitation with intravenous fluids and broad-spectrum antibiotics covering gram-negative and anaerobic bacteria. For investigation, the most sensitive and specific imaging is a CT scan of the abdomen and pelvis with both oral and intravenous contrast. This will confirm the presence and location of the leak and any associated fluid collection or abscess. The management then depends entirely on the patient's clinical status and the CT findings. A small, contained leak in a stable, well-appearing patient might be managed conservatively with antibiotics and CT-guided percutaneous drainage of any collection. However, for a patient with generalized peritonitis or any sign of clinical instability, the only safe option is an immediate return to the operating room. The goals in surgery would be a thorough washout of the peritoneal cavity, control of the septic source, and definitive drainage. This often means creating a diverting stoma if one isn't already present, and in severe cases, it may require dismantling the anastomosis and creating an end colostomy. Prompt recognition and aggressive management are key to preventing mortality from this complication.